So good afternoon, everyone. Probably it's going into evening for where you are. I'm actually in sunny Grimsby at the moment. So welcome to the first ophthalmology live class from the Farz Academy. So today we will be covering some hot topics in ophthalmology, and I'd just like to highlight the first H in ophthalmology, which people tend to forget. So the first hot topic is actually pink eye in COVID-19. So 1 to 3% of people with COVID-19 will get a pink eye. So this happens, excuse me. So this happens when the virus infects the conjunctiva, covering the sclera or the inside of the eyelids. And the symptoms are, as with any viral conjunctivitis, red eyes, swollen lids, and itching. So one of the emergencies in ophthalmology is an acute red eye, and this is the typical picture we get in a bacterial corneal ulcer. If I could just highlight. So that is the bacterial corneal ulcer, and you can see the intense red conjunctival injections surrounding the cornea. So the treatment of this would be with a topical antibiotic like ciprofloxacin or ofloxacin 0.3%. And if it is in a very dire straits, then we might need fortified antibiotics like tobramycin and gentamicin. Cycloplegics are used to relieve the pain or ciliary spasm, and you need to warn the patient that their vision will be blurry with these drops, and they're not to drive while on these drops. So you might get a picture like this for a spot diagnosis. You can see an ulcer-like tree branches on the cornea, and this is typical of a dendritic ulcer or viral keratitis. And when it is stained with fluorescein, it shows up as greenish yellow in the cobalt blue light. It looks very pretty, actually. So around 50% of scleritis patients have an underlying disease, of which the majority are connective tissue disorders. And amongst those, rheumatoid arthritis is the most common. Scleritis can also be seen in the following diseases. Is everything okay? Hope so. SLE, reactive arthritis, PAN, ankylosing spondylitis, gout, Churg-Strauss syndrome, syphilis, and Wegener's disease, also known as granulomatosis with polymyositis. Scleromalacia perforans is a rare form of scleritis in only about 5% of cases, caused by necrosis of the sclera, as can be seen here. The uveal tissue is visible through the thinned out sclera. There is minimal or no inflammation and therefore usually no real symptoms. It's bilateral and usually only seen in severe advanced rheumatoid arthritis. So chronic glaucoma or primary open-angle glaucoma is the silent thief of sight. Now here I've just highlighted a normal optic disc on the left and a typical glaucomatous cupping, advanced cupping in POAG on the right. Behcet's disease is another hot topic. Typical findings include severe anterior uveitis with a hypopion or collection of pus inside the anterior chamber at the bottom here, retinitis, retinal vasculitis, and disc inflammation. The clinical course is usually severe with multiple recurrences. Diagnosis requires the presence of associated systemic manifestations like oral aphthous or genital ulcers, and you can get other diseases like dermatitis, like including erythema nodosum, thrombophlebitis, or epididymitis. So there are no lab tests for this disease, but it is associated with HLA-B51. Treatment is with local and systemic corticosteroids and a cycloplegic mydriatic drug to alleviate the acute exacerbations, but eventually most patients need systemic steroids, sometimes even a non-corticosteroid immunosuppressive drug for the inflammation and to avoid the serious complications of long-term steroids. Biologic agents like interferons and TNF inhibitors have been effective in selected patients who are unresponsive to other therapies. Alkylating agents have also induced remission in some. So this is another ophthalmic emergency and a hot topic, acute anterior uveitis. And it tends to be the most symptomatic amongst the uveitis, especially when acute. And these manifestations are pain, redness, photophobia or light sensitivity, and a variable amount of decreased vision. So compared to the corneal ulcer, you can see the intense, it's actually called ciliary injection, and it's closest to the limbus, which is the junction of the cornea and the sclera. You can see the irregular shape of the pupil, and you can just about make out some white dots, which are actually on the corneal endothelium and typical of this disease. So pupils are so important that you could get 10 questions on them if they had more questions from ophthalmology. So this is definitely a group of the hot topics. You need to know the pupillary light reflex pathway, and you can remember that the pretectal fibers from the pretectal nuclei, each one goes to both sides as Edinger-Westphal nuclei, so that if you shine a light in one pupil, that affects both pupils and they both constrict, and that's the direct and consensual reflexes. So when you're checking the direct and consensual pupillary light reflexes, you need a dim light, and you ask the patient to focus in the distance to avoid accommodation, because as you know, the pupils constrict in accommodation. Shine a beam of light into one pupil and you check the same pupil, and then again you shine the light and check the opposite pupil. Both of them should constrict briskly and equally. Ipsilateral pupillary constriction is the direct response, and contralateral constriction is the indirect or consensual response. So then we come to the variations in pupil size. So if the pupils are less than 2 millimeters diameter, that's meiosis, and causes include Horner syndrome, old age, pontine hemorrhage when you get pinpoint pupils, Argyll Robertson pupil, certain drugs and poisons. Likewise, when the pupil size is large, more than 6 millimeters, we call it mydriasis. Causes include acute angle closure glaucoma, which of course is an emergency, Holmes-Addy or myotonic pupil, third nerve palsy, which could also be another emergency, head injury, comatose patient, drugs and poisons like atropine and others. So in the Holmes-Addy myotonic pupil, the most common symptom is the patient will come and say, my pupil is enlarged, and it wasn't like this before. So the pupil usually remains dilated even in the presence of bright light, and this is a left Holmes-Addy pupil. As you can see, the pupil is dilated in this side. Symptoms include blurred vision, impaired vision, trouble with depth perception, and light sensitivity or light glares. Usually only affects one eye. They may, however, eventually involve both. Now, this could come as an MCQ, I have not heard of Ross's syndrome before this presentation, but it's technically the combination of decreased sweating, missing reflexes, and weak pupil responses. Some clinicians describe it as a variant of AD syndrome, but it's good to know the name, Ross's syndrome. Horner syndrome could be another emergency, causes ptosis of both the upper and the lower lids, so that the lower one is called inverse ptosis. You can see the pupil size is smaller on the affected side, so miosis, and there is a dilatation lag in the affected eye, as well as ipsilateral anhidrosis or lack of sweating. So this results from a central or peripheral lesion, which may be pre or postganglionic, that disrupts the cervical sympathetic pathway running from the hypothalamus to the eye. Diagnostic tests are pharmacological, so we use cocaine drops if we can get hold of them. They're notoriously difficult to get these days. Aproclonidine eye drops or hydroxyamphetamine drops, and that helps to confirm the location, whether it's pre or postganglionic. So usually after installation of cocaine, which blocks the reuptake of norepinephrine, about an hour after installation, the normal pupil dilates more than the Horner's pupil. Aproclonidine is an alpha-adrenergic agonist, which again causes pupillary dilatation due to denervation sensitivity, and a reversal of anisocoria after instilling the 2 drops is suggestive of Horner's. But beware, you can get a false negative result in acute cases because the upregulation of alpha-1 adrenergic receptors on the dilator pupillae is not present immediately after the injury, but happens about 5 to 8 days afterwards. Hydroxyamphetamine causes the release of norepinephrine as well, and about an hour after installation, it dilates the pupils. So if the smaller pupil fails to dilate, it indicates a lesion of the 3rd order or a postganglionic lesion. Acute onset of painful Horner should be considered a neurological emergency, and the subject should be evaluated for dissection of the internal carotid artery. These patients are at increased risk for cerebral infarction, so an MRI or CT of the brain, spinal cord, chest or neck, depending on the clinical suspicion. And although there's no treatment for primary Horner's, if there is a cause identified, it needs to be treated. This is a congenital Horner's, and the difference is quite marked. You can see the ptosis and the inverse ptosis and the meiosis as well. So Argyll Robertson pupil was first described in the mid-1860s by Dr. Douglas Argyll Robertson, a Scottish ophthalmologist. And this happens when the disease interferes with the light reflex pathway, inhibiting the pupil's natural response to bright light. So here the pupils don't constrict in response to light, but do constrict to focus on a nearby object. This presence of this disease or pupil is typical of tertiary syphilis, although can be found in other diseases like diabetes, trauma, neurosarcoidosis, chronic alcoholism, and others. But do you remember the main point of Argyll Robertson pupil? ARP, accommodation reflex present. Just an easy way to remember. So the pupils do constrict to a near object, but do not constrict when exposed to light. Marcus gun pupil or relative afferent pupillary defect, RAPD. Both pupils dilate when the light is moved from the unaffected eye to the affected eye, but when we shine the light on the affected side, both the pupils dilate instead of constricting. And this is mostly seen in unilateral optic neuritis. So in the left, we can see the normal and the direct and consensual reflexes. In the affected, when the left eye is affected, you shine the light on the normal side and both pupils constrict. When you shine the light on the abnormal side, where the optic nerve is affected in the left eye, both pupils dilate. Why does this happen, you say? Because the pupillary dilatation produced by removing the light from the normal right eye is greater than the pupillary constriction caused by the light in the defective left eye. So this is known as RAPD. Don't forget acute angle closure glaucoma, a medical emergency where you can get a fixed oval mid-dilated pupil in an acute red eye, as seen here. The cornea is a little cloudy as well. So if you have a situation where you have a dilated pupil and you're wondering what it can be, we first try usually a weak 0.1% pilocarpine, a direct cholinergic agonist, and that causes pupillary constriction in AD's tonic pupil, as seen here. If it doesn't respond, then we have to think of something else, and we try a concentrated or 1% pilocarpine. If it does constrict the pupil, it is a third cranial nerve palsy, which could be an emergency as well. And if not, it is likely to be a pharmacologically dilated pupil as due to atropine 1%. So one other pupillary point I would like to point out, and you could actually save a child's life by diagnosing leukochoria or white pupil reflex as seen in the left eye here. It's quite easily visible on photographs as well, and we always have to exclude primarily retinoblastoma, which, as you know, is a malignancy of the retina, and there are other causes like congenital cataract, VHPV, endophthalmitis, and choroid coloboma. But retinoblastoma must be excluded as it is life-threatening and sight-threatening. So this is a summary of some of the different pupil abnormalities. So we've got the pathway, the pupillary light reflex pathway, normal pupils, meiosis, mydriasis, Horner syndrome, unilateral dilated pupil, accommodation, and showing off the consensual light reflex. The second link here on the right has some very useful flashcards if you want to check that out later. You do get a 1-week free trial, but you need to sign up, and I found it quite useful. Cranial nerve palsies. There are many, of course, but the ones related to the eye. The one which is most important is, of course, the third nerve palsy, and this is another hot topic for us, especially if the eye is painful, there's a headache, and there is a dilated pupil. So we must rule out the surgical causes first. So here on the right side, you can see that the eyeball is deflected downwards and outwards. The pupil is dilated compared to the normal left side, and there is a complete ptosis which has been lifted up by the thumb. So, for example, if you get a dilated right pupil in this 53-year-old gentleman, he had an acute onset of headache and complete closure of the right eye. This has been held up by an instrument here. The pupil was non-reactive. Associated findings in the same eye included a complete ptosis, exotropia, meaning the eye is turned outwards, hypotropia, the eye is turned downwards, impaired medial rotation or adduction, elevation, and depression. So an isolated pupil involving third nerve palsy should immediately prompt consideration of an intracranial aneurysm, especially and particularly when pain is present. Tumors at the skull base are also in the differential diagnosis. So other cranial nerve palsies for ophthalmology, the second nerve, of course, optic nerve, the third, fourth, and sixth, as well as the seventh cranial nerve. Now this website, ophthobook.com, is an excellent one with videos as well. It is simple and easy to understand. This is what I like about it. So you might want to check this out when you get the time. Sorry, my throat tends to get dry. So facial nerve paralysis patients often have dry eyes. I'm sure you all know how to diagnose a facial nerve palsy, but they are excuse me, they are at risk of exposure keratopathy, which can actually be blinding. So this is why the ophthalmologist comes into the care of these patients.